How do TB drugs cross the placental barrier in pregnancy? Imagine a mother fighting tuberculosis while carrying her baby. How do the medicines she takes reach the developing fetus? The answer lies in how drugs pass through the placental barrier. The placenta acts as a selective filter, allowing some substances to cross while blocking others. Most tuberculosis drugs cross this barrier mainly through a process called passive diffusion. This means the drugs move from the mother's blood into the fetal circulation based on their chemical properties. Drugs that are small in size and soluble in fats tend to cross more easily. For example, isoniazid and rifampin are both small molecules and lipid-soluble, so they can pass through the placental membrane readily. This allows the fetus to be exposed to these medications at levels that can be effective against tuberculosis. Ethambutol also crosses the placenta, though to a lesser extent, and pyrazinamide does as well, but data on its safety during pregnancy are still being studied. The transfer of these drugs depends on several factors. Smaller molecules cross more easily than larger ones. Lipid-soluble drugs penetrate the placental barrier more efficiently than water-soluble ones. Drugs that are not highly ionized and are non-ionized tend to pass through more readily. Additionally, if a drug binds strongly to maternal plasma proteins, less free drug is available to cross into the fetal blood. Current evidence suggests that the first-line TB drugs used during pregnancy do not cause significant harm to the fetus when used properly under medical supervision. For instance, when pregnant women take isoniazid and rifampin, these drugs reach the fetus but generally do not cause birth defects or other serious issues. To reduce potential side effects, doctors often recommend supplementing with vitamin B6 when using isoniazid. It is important to remember that physiological changes during pregnancy, such as increased blood volume and altered metabolism, can influence how drugs are processed in the body. These changes may affect drug levels in both mother and fetus, so careful monitoring and dose adjustments are often necessary. Some second-line drugs used for multidrug-resistant tuberculosis, like fluoroquinolones and bedaquiline, also cross the placenta, but their safety profiles are still being studied, and they are used cautiously. The decision to treat tuberculosis during pregnancy involves balancing the benefits of controlling the disease with the potential risks to the fetus. In summary, tuberculosis drugs mainly cross the placental barrier through passive diffusion, with small, lipid-soluble drugs like isoniazid and rifampin crossing easily. This allows effective treatment for both mother and baby, provided the therapy is managed carefully by healthcare professionals. Always consult a healthcare provider for personalized advice and treatment options during pregnancy.